Okay, I'd like to thank you all for taking the time to come today. You're at the joint replacement class. My name is Jan Vandermolen, and I'll be conducting the class today. And very importantly, we'd like to thank you for choosing the University of Chicago Medicine for your medical care and allowing us to be on this journey with you for your joint replacement. The class will be following the syllabus that you have in front of you. It'll also be on the screen as a PowerPoint. If you have any questions while I'm talking, there are spaces on the syllabus that you can jot your questions down, and I'd appreciate it afterwards. You come and ask me all those questions. Do not leave today until you have those questions answered. This is part of the team that you'll be seeing while you're here in the hospital. Dr. Liu is a hip and knee replacement specialist that also has a dual interest in bone reconstruction for cancer people. I am Dr. Liu's nurse. We actually have another orthopedic surgeon here. It's Dr. Athavaraham. He does knee replacement surgeries, and he has a dual interest in sports medicine. And his nurse is Jennifer Lawrence. We both feel that if you have any questions in the process towards your joint replacement, call us. We like to say, if you're concerned, we're concerned. Call us and ask us. In the packet that you received in the mail, there was a little checklist. And I'd like you to be working on that checklist as you progress with your joint replacement surgery. It gives you things that you should be doing ahead of time, and then just keep following that. And we will be talking about different items on this checklist during this talk today. I'm going to give you a brief lesson on anatomy. This is a knee replacement. This is the big femur bone that goes up on your thigh. Down here is your tibia and fibula, and in the middle here is your knee joint. And in the middle here is cartilage or meniscus, and this is what your bones actually are cushioned with. This is what prevents that pain. When you need a knee replacement, this is the part of your knee that's been destroyed or there's something wrong with it. So you're no longer having a cushion in between your bones. And the same thing with the hip replacement. This is the femur bone. This is the big bone on your thigh bone. This is what we call the head of the femur. And this fits right into the pelvic area. And in this pelvis, you'll have that meniscus or that cushion. And once again, that's what prevents the pain when you have bone on bone. And when you need a hip replacement, the cushion here or the meniscus is what's destroyed. There are certain reasons for joint pain. Degenerative disease, bone on bone, or destruction of cartilage. And they're all the same thing, talking about the same thing, just different ideas, a way to say it. This is an x-ray of an arthritic hip and a normal hip. If you see the hip on the right side, you can see how round the head of the femur is. On the other side, you can see that it's kind of diffused and you don't see a nice round head. Kind of another look of arthritic and normal hip. And the same thing is with a healthy knee and arthritic knee. The one on this side is a normal knee. You see some space in between there, which is not actually space. That's actually your cartilage or your meniscus. And that's not picked up on x-ray. So it looks like space, but the one on this side has some nice, healthy space or meniscus. The one on the other side, you can see the femur bone is grinding into the tibia bone. The meniscus there is destroyed, and that's where you get bone on bone pain. Some of the reasons for the cartilage destruction or the meniscus destruction is past history of injury. A lot of my patients will say they had an injury when they were a child, when they were playing ball or something, and it wasn't even manifested till years later. Just because there is an injury, it doesn't mean you're going to have arthritis, but a lot of times they can pinpoint a time in their life where they had quite a significant injury. Medications can also cause destruction of cartilage, especially people who are on high doses of steroids, people who take steroids for asthma. A steroid is a medication that actually is a life-saving medication, but it also has a potential to destroy cartilage too. And once again, just because you are on high doses of steroids for a long period of time, it doesn't mean you're going to have a replacement, but there does seem to be correlation between the two. Another one is avascular necrosis, which is just a decreased blood flow to the joint. Rheumatoid arthritis is another disease that affects all the joints in the body. And that's when you see a rheumatologist and he gives you some medications for that. The most common disease that affects cartilage is osteoarthritis. And osteoarthritis can affect one joint or it can affect many joints. And I have read all kinds of literature. There's no predictors about if you have osteoarthritis in one knee or one hip, you're going to have it in any other ones. There's no predictor. So you could just have it in one knee and not get it in the other hip. But there does seem, or other knee, excuse me, but there does seem to be some kind of path that it does show in both knees or both hips. And there also seems to be a genetic component to it. A lot of my patients will say, my mother had a hip replacement. My sister just had her knee replaced. So there does seem to be a genetic component, but once again, studies can't directly correlate that. So what do we do when you come to Dr. Lou or Dr. Athavaraham? The first thing we'll probably ask you to do, try anti-inflammatory medications. Now, anti-inflammatory medications are medications that do not affect the cartilage, but because there's fluid that's produced in your hip or the knee, it makes your knee feel tight and swollen. And so these anti-inflammatory medications take away some of that fluid to produce less pain. It has no effect on the cartilage, but it does take away some of that fluid to make your knee feel better. I think especially some of the knee patients, they say, my knee feels so tight. And that's just the fluid that's produced. And because we're asking you to take Aleve, Motrin, ibuprofen, those are all medications, and if they don't help anymore, we ask you to stop them. We never advocate taking medications if they're not working. And then the next step we have is injections or shots, whether it's in your hip or in your knee. And those can be done every 3 months for as long as they work. And once again, those are anti-inflammatory, does nothing for the cartilage, but it takes away the fluid to make the joint painful. So you can have those as long as they're working, but once again, once they're not working, doctor will say we need to talk about the next step. It's a medication, and we never advocate continuing with something that doesn't work. And then the third step is surgery, which is why you're here. And your doctor will discuss the different forms of the surgery and what's the best for your particular disease. One thing you need to know about joint replacement surgery, it's optional or elective procedure, which means you never have to have it. It's not life-saving, but we really feel it's life-changing. And so we'll talk about different things. So it's an optional procedure. Your family cannot say you need to have this. Your minister, your neighbor said, oh, I had it, just go ahead and have it. It has to be a very personal decision between you and your doctor. What is best for you? So it is an elective procedure. And a lot of my patients say, well, Jan, when shall I have this procedure? And there are different things that I ask you to consider. One of them is your life being changed by this painful hip or painful knee? You're saying no to things that you used to enjoy, such as going to church, restaurants, out with your grandchildren, taking walks, theater, because it's very, very difficult to drag a leg around that is always in pain. So that pain is just always there. And it's changing your life. It's changing the things that you like to do. So is your life being changed? Maybe it's a time to start considering it. We also talk about work situation. A lot of the people who are having joint replacements now are younger, and they are still working. We ask your employer, for 12 weeks off. We usually can send you back earlier, but it's better for us to give them the outside time than to give them a shorter time and ask to send you back earlier. So about 12 weeks. So make sure your employer knows what's going on. The University of Chicago also has a care partner program, and that's probably something that's in your packet when we mail to you, which means we want to take this journey with you, but once you leave us at the hospital, we want to make sure that there's someone there who's going to help you. So we'd like you to identify a care partner who's going to maybe make a meal for you, provide transportation, just give you pep talks if you need it. So we'd like you to identify a care partner in your life. And then last of all, then you have discussed all this with the doctor, it is major surgery, and we have to make sure that the benefits outweigh any of the risks that come with any major surgery. One of the first risks that we talk about is infection. The University of Chicago is very concerned with that. The national average of joint infections is 2%. Dr. Athavaraham and Dr. Liu have it down to about less than 1%. So we do take it very, very seriously. An infection in your joint could possibly mean we'd have to take the joint out and put it back in at a later date. It's usually like 6 to 8 weeks. So that's a possibility. If it becomes infected, we may have to take it out and put it back in later. So an infection in your joint is really a catastrophic event. So like I said, Dr. Liu and Dr. Athavaraham are very concerned about infections. So what do we do about that? The first thing we do, we have you see a dentist. We know that our mouth is the dirtiest part of our body, so we need to have a dentist look at our mouth and say there's no infection, there's no decay, everything in there looks good. And then you can proceed with the surgery because the dentist will fax over that clearance and will know that that's one less concern that we have. The dentist has cleared you. Now that dental treatment and dental procedure is a lifelong commitment. We need you to see a dentist every 6 months for the rest of your life. And before you step into the dentist's office, you need to take an antibiotic. And we will supply the antibiotic or your dentist will. It's just one dose an hour before you see the dentist. Now, the Dental Association actually came up with these recommendations